Good morning, all. We are continuing with fixed space maintenance. We have already discussed about the factors governing giving a space maintainer and removable space maintainer. Today, we are going to discuss about fixed space maintenance. Premature loss of primary tooth can cause loss of partial length, crowding of permanent tooth, and impaction of permanent tooth for aesthetic issues, malocclusions, and other problems like development of aberrant habits. Space maintenance begins with good restorative treatment, and the best space maintenance is the natural tooth itself. Coming to fixed space maintenance, the fixed space maintenance utilizes bands or crowns for their construction. This band is attached to the tooth or cemented to the tooth, or a crown is used to cemented to the abutment tooth. Common fixed space maintenance include band and loop space maintainer, lingual arch space maintainer, crown and loop space maintainers, palatal arch space maintainers that includes both non-palatal arch and transpalatal arch space maintainers. Then fixed appliance for anterior space maintenance includes dopper space maintainer and bonded space maintainers. Advantages of fixed space maintenance are easy manipulation, and the bands are used without tooth preparation or with minimum tooth preparation in case where we are using crowns. It does not interfere with passive eruption of abutment, and jaw growth is not hampered. The successorious permanent teeth are well guided to their positions, and they can be used for uncooperative patient. That is, the patient complaints is required less because it is fixed appliance, and masticatory function is restored if we are using bondings. Disadvantages: that elaborate instrumentation with expert skill is needed because banding of the tooth and making of wire component, all these soldering, welding, all these procedures are there, and may result in decalcification of tooth material under the bands and may be harmful to the abutment tooth due to development of forces resulting in appliance breakage and rotation of the tooth and supra-eruption of opposing tooth if it's not a functional space maintainer. And if we are using bondings, then it interferes with vertical eruption of abutment tooth and prevents eruption of replacing permanent tooth. And the fixed space maintenance requires long laboratory time and may require some preparation of abutment teeth. Armamentarium used for fixed space maintenance are band construction instruments and loop or arch construction instruments, then soldering unit, polishing stones, and wheels. The band material used for each tooth is different. For first permanent molars, we're using 0.180 into 0.006 inch or 0.180 into 0.005 inch band material. For deciduous first molar, 0.150 into 0.004 inch or 0.125 into 0.004 inch, and deciduous second molars, 0.150 into 0.004 or 0.180 into 0.005 inch type of band. These dimensions indicates its width and thickness of the band material. These are different types of pliers used for band construction and wire bending. That is big plier, straight and curved core pliers, contouring pliers, that is Johnson contouring plier, and pliers used for making wire components or loops. This band pusher and band seater, and finally band remover from the tooth surface. Coming to banding procedure, band is made from stainless steel material, and this band has got a dull surface and a shiny surface. The dull surface will face the tooth, that is, it faces the tooth surface, and the dull surface helps the bands to hold the cement in place, and the shiny surface is facing outward. So the food debris or the material will slide off. So the dull surface is used to face the tooth surface. About 2.5 inch length of the band material is cut off and with using scissors, and the loop is made by facing two dull sides against each other, and spot welding is done. The tangent ends of the band materials are rounded and curved using grid scissors. Then the band material is applied onto the tooth structure and trial pinching is done using band forming pliers. Then festooning is done. Festooning means contouring of the band material to adapt to the gingival margin or to follow the gingival contours. Then trimming is done to adjust the occlusal gingival or occlusal cervical length of the band, especially on the buccal and lingual side, and the same extra amount of band is cut off and rounded, and that small remnant is adapt to the remaining band. The extension of band buccally just below the level where opposing cusps touch the groove. Lingually, it's just below the deepest portion of lingual development groove. Proximally, it should be 1 to 1.5 mm below the marginal ridge, and gingival margins should extend 0.5 to 1 mm into the gingival sulcus. Then, after banding is completed, we have to go for impression taking and cast preparation. Alginate or compound impression of banded tooth is done. In case of full arch space maintenance, such as lingual arch space maintenance or transpalatal or transpalatal arch space maintenance, full arch impressions are made, and only sectional impression is needed for a single tooth replacement space maintenance, such as band and loop or distal shoe space maintenance. After taking the impression, the band is removed from the tooth surface and place it on the impression in position exactly on the abutment tooth where we have done banding. And we have to stabilize the band using wire, stainless steel wire. Then impression is poured and stone cast is made. Coming to each type of fixed space maintainer. First one is band and loop space maintainer. It's a cantilever type of fixed space maintainer. That is, usually the distal abutment tooth is banded. It consists of band cemented to the tooth posterior to the edentulous space or distal to the edentulous space, and loop or wire across the edentulous space abutting the anterior tooth. Indication for fixed band and loop space maintainer, that is premature loss of any primary molar in transitional dentition and premature loss of a primary second molar after the eruption of first permanent molar, and bilateral loss of primary molar before the eruption of incisors. It is because we cannot give lingual arch before the eruption of permanent incisors, because the tooth is erupting, the permanent incisors are erupting lingually to the primary tooth in mandibular arch. So bilateral loss happen before the eruption of permanent tooth in mandibular arch. In such cases, we have to give separate band and loop on both sides. And sometimes it is given in case of premature loss of primary canine also. Contraindications: if the occlusion is extremely crowded or marked space loss is present, high dental caries activity, because banding can increase the demineralization potential. Then replacement of primary anterior teeth, we cannot use a band and loop type of space material, and replacement of primary second molar in primary dentition, that is before the eruption of permanent first molar. Advantages: it's an effective space maintainer for unilateral loss of single tooth in buccal segments. It's economical and simple construction. It takes less chairside time if we are using preformed bands and preformed loops. It can be adjusted easily to accommodate the changes in developing dentition. Coming to disadvantages, it does not restore the masticatory needs, or it is not a functional type of space maintainer. And it does not prevent the supraeruption of the opposing teeth, and it can cause decalcification under the bands and limited to maintenance of single tooth space loss. And it is a passive space maintainer, and it's more prone to slip gingivally during mastication and cause soft tissue injuries, and may cause eruption disturbance if it is distorted or if the patient is not reported timely. Coming to the construction, select appropriate band, then band seater and band pusher are used to adapt the band. Then impression is taken. After removing the impression, band is removed from the tooth surface and placed it on the impression and stabilize the band from the cast. Then wire loop is made. Wire is held at right angles to the peaks of the pliers, and loop should tip towards the ridge parallel to the soft tissue, and finished loop should be at the middle third of the band. And solder the wire to the band and cut the excess wire. Appliance is removed from the cast and should be polished. This is banding is done and cast is made, and then loop is adapting. It should follow the gingival contour, and then finally we have to solder. Then dry in the appliance and check for occlusion, any occlusal disturbance, and remove the appliance and cement it using DIC or zinc phosphate cement. The loop of the band and loop space maintainer, it should be parallel to the edentulous ridge and 1 mm away from the soft tissue or gingival tissue, and should rest against the adjacent tooth at the contact point. If it is below the contact point, it will easily slip into the gingival tissue. Then faciolingually, or the width of the loop is approximately 8 mm. That is the buccolingual width of the premolar. So it will allow the permanent tooth to erupt freely into the loop, and should not restrict any physiologic tooth movements. That is when in case of active intercanine width increase. Recall and maintenance of this appliance. Patient should be recalled every 6 months to check the fit of the appliance, whether the appliance become loose or not, and if whether the cement has washed out or not, and to check the integrity of abutment tooth. We have to remove the band and loop space maintainer when the permanent tooth is erupting into the space. McDonald and Avery suggested that the band and loop space maintainer should be removed once a year and see whether any decalcification is present or not, and clean the tooth surface, and topical fluoride application should be done before the re-cementation of the appliance. Coming to modifications of band and loop space maintainer. One is bonded band and loop. Instead of soldering, we have to bond the material wire loop onto the tooth, and it is difficult to keep the wire bonded to the tooth surface and difficult to adjust. Then crown and loop space maintainer. Instead of banding, we are placing a crown on the tooth, especially if the abutment tooth has undergone any pulp therapy. In such cases, we have to give a stainless steel crown, and onto that we are fabricating a loop, and it is difficult to adjust intraorally. Then long band and loop. If more than one tooth is missing in the same side, or the like in first and second deciduous molar is missing, then banding on the first permanent molar is done, and long loop is made to reach till the canine area. Then band and bar. This is we are banding the abutment teeth on the both sides, that both mesial and distal side tooth are banded, and it is connected with a bar, stainless steel wire. Then Mayonnaise modification, that is orthodontic band is or crown is used on the erupting permanent molar, and cantilever type of wire is extended. That is, the loop is half. Only one side is present for the loop. Then band and loop appliance with occlusal rust. It prevents the gingival tipping of the appliance and the abutment tooth, which can result in gingival irritation. So the occlusal rust prevents the gingival slippage of the loop. The reverse band and loop. When second primary molar is lost during the eruption of first permanent molar. In such cases, we are banding the first primary molar and the loop is directed distally to the erupting first permanent molar. That is known as reverse band and loop. Then fiber reinforced composite loop space maintainer. It's a bonded type of material. And here fiber reinforced fibers are used to make a loop. Coming to next fixed type of space maintainer, that is lingular space maintainer. It's popularized by Burstone, and it consists of a heavy gauge wire that is adapted to the lingual aspect of the mandibular arch, attached to the bands of the first permanent molars. Banding is done on the first permanent molar. Then the wire is extending from the first permanent molar on one side to the other side through the cingulum of the anterior tooth. Indications: maintenance of arch perimeter, mainly in mandibular arch, and maintenance or prevention of mandibular changes in arch length, overjet, overbite, etc. That is, it maintains the integrity of arch and prevents the lingual collapse of anterior segment and retention or stabilization of mandibular anterior teeth. Coming to contraindications, in situations where frequent adjustment is required or rampant caries or high caries index, poor patient cooperation, anterior or posterior frostbite or extreme mandibular crowding, especially in anterior segment. Advantages: it's an excellent source of anchorage and allows free movement of teeth while maintaining the space in the desired arch. So it will not interfere with the normal growth. Little or no inconvenience to patient compared with the removable space maintainers. It serves as a space maintainer for more than one tooth is missing. Disadvantages: decalcification of banded tooth, archware irritation embedded into the soft tissues, that is patients with poor oral hygiene, and wire can be distorted with masticatory process. Coming to modifications of fixed lingual arch appliance, it can be used as a space regainer, that is known as forced lingual arch, where a U-loop is incorporated at the premolar area. So the activation of U-loop will help in distalization of first permanent molar, thus we can regain space. Then addition of canine spurs distal to the deciduous canine. So it helps to maintain the anteroposterior length of the dental arch. It will prevent the distal movement of or distal drifting of the canine. Next fixed space maintainer is transpalatal arch. It includes a straight bar extending across the palate. That's why it's known as transpalatal arch, and it is adapted to the palatal wall 2 to 3 mm away from the palatal mucosa, and an omega loop is incorporated midway across the intermolar area. Indication: when one side of the arch is intact and several primary teeth on the other side is missing. If a single tooth is missing, we can go for a banda loop space maintainer. But in case of multiple tooth loss unilaterally, we can go for a transpalatal arch. It has got another application also. We can correct unilateral frostbite using this palatal arch. Advantages: better compatibility with soft tissues and increased vertical control, especially when one side of arch is intact. Disadvantages: Some patients report with food debris entrapped between the transpalatal wire and palate. Next is transpalatal appliance. It is developed by H.M. Nance. It consisting of a bands on both sides, like either first permanent molar or primary molar, and the stainless steel wire is soldered onto the palatal aspect of the first permanent molar bands. The wire is running anteriorly, and it is attached to an acrylic button anteriorly. This acrylic button is pressed against the rugae area. Indications: when there is bilateral premature loss of primary teeth, and it's also used as a habit breaking appliance when we are incorporating spurs into the acrylic button that is present anterior area. Contraindications: if there is any palatal lesions present or first permanent molar is not erupted. Next is Groper's appliance. It's a fixed functional anterior space maintainer. It's similar to Nance holding arch, but acrylic teeth is processed to the wire instead of palatal acrylic button. The teeth are attached to the metal plates and have been soldered to the palatal wire, and the teeth sit directly onto the alveolar crust without much extension of acrylic material to the vestibule or to the palatal side. Next is distal shoe appliance. It's also known as intra-alveolar appliance or distal extension space maintainers or eruption guiding appliance. This is indicated when a second primary molar is lost prior to the eruption of first permanent molar. If second primary molar is lost before the eruption of first permanent molar, this is the only appliance that we can use. Coming to indications and contraindications, indication is premature loss of second deciduous molar prior to the eruption of permanent molar. The primary molar can be lost because of atypical resorption or caries, etc. Then coming to contraindications, that is inadequate abutment. If both the primary molars are lost, like both first and second primary molars are lost, or poor patient or parent cooperation, missing permanent first molar, and systemic diseases that affect healing such as diabetes and cardiac anomalies that require antibiotic prophylaxis. In such cases, we cannot give distal shoe. Advantages of distal shoe: it's an effective appliance guiding the eruption of first permanent molar when it is in proper position, and it can be fabricated by direct or indirect method. Disadvantages: the distal shoe appliance is extending into the gingival sulcus and into the distal shoe appliance extended into the gingival tissue, and so the complete healing may impair, and it's not a functional appliance. There are different designs for distal shoe appliance. One is distal guiding shoe, and it is made up of cast gold, and it is of more cost and difficulties in tooth preparation. Then Roche gave another design in 1972. That is placement of crown or band appliance with distal intragingival extension. That vertical extension is V-shaped. That is because it gives a broader surface and it prevents the rotation of erupting permanent first molar. How will we decide the horizontal and vertical length of the distal shoe appliance? The length of the distal extension or the horizontal extension is measured either by measuring the second primary molar or measured from the radiograph. That if already we lost the second primary molar, then we can measure from the radiograph, or the distance between the distal surface of the primary first molar and unerupted permanent first molar. That is, can be measured from radiograph, or measure the mesodistal width of the opposite arch. Not opposite arch, opposite quadrant. Then the depth of distal extension, that is the length of the vertical arm. If the vertical arm should extend 1 mm below the mesial marginal ridge of the unerupted permanent first molar. It can be cemented on the same day. It should be cemented on the same day of the extraction of second deciduous molar. If the vertical extension is too long, it injures the developing second premolar. And if it is too short, unerupted permanent tooth is clipped under this vertical extension and it interfere with the eruption. How will we follow up in case of if we are giving a distal shoe appliances, like with partial eruption of permanent first molar, if every 3 months we have to recall and check the eruption status of the permanent first molar. If it is partially erupted, reverse band and loop we can give, and if it is completely erupted, then band and loop space maintainer, and after the eruption of incisors we can shift to lingual arch space maintainer. In case of maxilla, it is transpalatal arch. There is EZ space maintainer. It is a bonded type of space maintainer introduced by Ennis Gure. It is no banding is required, and it will not interfere with the eruption of subcutaneous tooth. Advantages are easy to fabricate and economical. Bands or impressions are not required. It can be completed in one appointment and permits normal eruption of permanent teeth. And decalcification and periodontal damage is very less than compared to banded space maintainers. It can be used in partially erupted teeth because banding is not needed. It's more aesthetic and can be bonded either buccally or lingually. And recall and maintenance and follow-up of fixed space maintenance or removable space maintenance. The space maintenance is a dynamic process, so frequent evaluation is required, and recall the patient every 2 to 3 months and checkup should be done. In case of removable appliance, we have to check whether the patient is wearing it or not, and check for distortion or breakage of appliance or any soft tissue injury. And if the tooth is erupting, we have to give or we have to remove the acrylic area and give the space for erupting tooth. And in case of fixed appliance, we have to check for breakage and so any loss of material, soldered joints. And we have to check for the appliance whether it is loose or any dissolution of cementing material is present, and if there is any decalcification or food lodgement or any presence of caries on the banded tooth should be checked. Either we can remove the appliance every 6 months to 1 year, and depending upon the caries status of the patient, and we have to polish the tooth and apply topical fluoride before re-cementing the appliance. The radiographic examination of developing teeth should be necessary between the recall visit. As we discussed already, 1 mm of bone, to travel through the 1 mm of bone or for erupting through the 1 mm of bone, it takes almost 6 months, 5 to 6 months. Depending upon the amount of bone remaining, we have to assess radiographically. And decalcification is checked by either by removing the band or checking by drying the tooth surface. So the best space maintenance is a primary tooth itself. So if possible, we have to do the restorative procedure or endodontic procedure to maintain that particular tooth in the dental arch till its exfoliation time or till the eruption of its succedaneous tooth. And if not possible or the natural space maintenance are lost, we have to go for a space management strategy. So this appropriate space management give proper aesthetics, proper functioning, and proper phonetics, etc. for the child. A dentist should review the variables and evaluate the decision according to the dynamic development of patient's dentition and plan accordingly for the space maintainer, whether to give a fixed space maintainer or mobile space maintainer, functional or non-functional type, depending upon the factors, it will be different for each patient. It's all about space maintenance. Thank you.